Thank you everyone for letting Genelex represent TCAP and support TCAP. I've already recognized how important this group is, and there's a lot of opportunities, even within the first presentation by Dr. Milner. We're talking about immune-mediated reactions. You know, pharmacists tend to be concerned about the IgE-mediated reactions, and we don't tend to think about, or we tend to dismiss these other reactions with the drug fillers and binders. So I think there's definitely an opportunity for pharmacists to raise awareness in the pharmacy realm about this issue. The multidisciplinary approach here is excellent and very important. I'd like to, give you my disclosures. I am a pharmacist with Genelex Corporation. I'm also an adjunct faculty member at Washington State University College of Pharmacy. Again, thank you to Barbara Granoff, Aurora Richards for allowing us to support TCAP. Special thanks to Dr. Henderson and Dr. Pusinki for recognizing the value in this early on in patients, being early adopters. And one more thing I wanted to mention is that there's definitely opportunities right now with genetic testing to get behind genetic testing as consortiums, and as you are all well respected in your amongst your peers, there's an opportunity for us to get genetics recognized as an important thing for patient care and get it recognized maybe in the guidelines or a standards of practice. So with that said, I'm going to do some recap of yesterday's presentation, and then I'm going to get into just more or less a survey of certain medications, especially medications we've been talking about the last 2 days, and how those are influenced by genetics. And then I'm going to hand it off to Dr. Pusinki to cover some case studies from his practice. Again, we are already using personalized medicine, and so I don't like to use the word personalized medicine when regarding pharmacogenetics. What genetics does, though, is it allows us to more precisely dose a medication. It allows us to optimize pharmacotherapy so that with the genetic information, we may indeed give that standard dose. We may decrease the dose, increase it, or use a different medication altogether. There's two areas of pharmacogenetics. There's pharmacogenetics of what we call them as pharmacokinetic biomarkers. These are, well, pharmacokinetics is what the body does to the drug. So this is pharmacokinetics, and that's basically blood levels of a drug. And so examples of these would be the drug metabolizing enzymes like the CYP450s, the glucuronidation pathways like UGTs, and then you have the transporters, which moves drugs in and out of cells. So SLCO1B1 is a very important one for statins. P-glycoprotein is extremely important for many drugs. Another type of pharmacogenetic test would be a pharmacodynamic biomarker. Pharmacodynamics is what the drug does to the body. And so you're going to have within pharmacodynamic biomarkers different subtypes. You have those that are the receptor of a drug, like OPRM1, VCOR. These actually directly influence how well that drug binds to the receptor and the response you get. You're also going to have pharmacodynamic biomarkers that are not directly related to the mechanism of action of that drug, but they're related to the disease state, and they can influence laboratory values during treatment. So those are extremely important. An example of that would be HLA-B star 1502, and that increases someone who's on carbamazepines risk of Stevens-Johnson's and toxic epidermal necrolysis. Our understanding of the pharmacokinetic biomarkers is, for pretty clear reasons, much better than it is for pharmacodynamic biomarkers. We can actually study the sequence of a gene and then measure blood levels. So we get a very direct correlation between the effect of the mutation and what it does. Whereas with pharmacodynamic biomarkers, we're often discussing and looking at subjective findings that are harder to measure. And oftentimes we don't know where the drug is, its full mechanism even resides. So with that, pharmacokinetic biomarkers will be our focus. And our core focus for pharmacokinetic biomarkers are these enzymes here. And the reason for that is together they metabolize about 75 to 80% of all hepatically cleared drugs. I actually just created this slide that similar to what Dr. Milner was showing earlier. This just shows that these mutations follow a Mendelian inheritability. So if my mom and dad are both intermediate metabolizers for a certain pathway, I can either be normal, I could get 2 good copies of the gene, I could be an intermediate, 1 good copy, 1 bad copy for the gene, or I could be a poor metabolizer and receive 2 bad copies of the gene. If that's the case, this follows basically the central dogma, genetics 101, DNA, mRNA, protein. If I don't have the gene, I don't express the protein, and therefore, if the drug utilizes that pathway, I don't clear it as efficiently. Most drugs have multiple pathways for metabolism, so oftentimes you don't get into trouble unless you're highly sensitive, like many of the patients we're talking about today are, or if you block a couple of the pathways that are responsible for metabolizing that drug. So that's something to keep in mind. Again, for those of you who weren't here yesterday, I utilized my time at home when my wife was asleep to take these pictures so I didn't get in trouble for photographing a messy kitchen or almost flooding the kitchen. But here's a bottle of Benadryl, and this is a normal metabolizer. Think of the sink basin as your patient. The water flowing into the sink is the drug you're prescribing them. And so that's right where we want that Benadryl. You know, here's an intermediate metabolizer. The blood levels of that drug increase. It's probably fine in most patients. Here's your poor metabolizer. That Benadryl is about to spill over the top. The water already is. That's beginning to look like toxicity, anticholinergic side effects, and that can begin to be problematic. And here's your rapid metabolizer. Someone with a duplicate copy of the gene, drug clearance is very rapid. You're not even getting up to therapeutic doses. So these are 4 of the very well-established phenotypes for these drug metabolizing enzymes. And the power and the beauty of understanding these before we prescribe is that we can begin to predict what dose we should give the patient. Oftentimes, we don't measure blood levels of drugs. There are some that we do, but when we're not doing that, we're assuming that it's going to be at a standard level in the patient, and that's not the case. So this is from the New England Journal of Medicine, and it shows that there are these direct correlations between the number of functioning genes and blood levels of a drug. Okay, implementation is simple. You screen a patient, you deliver informed consent. It's very easy. Cheek swab, harmless cheek swab. That's my daughter before she was, I don't even think she was one year old there. You then review results, and then you utilize those results throughout the care of that patient. And that's what makes this so key, is people will argue this is an expensive test, and the price is going to go down every year we go on here. But when you think of it in terms of treating that patient their entire life, the price of $1,000 around becomes pretty insubstantial. So what do you do? How do you utilize this information every time you fill a prescription, though, and every time you treat the patient with a new drug? That's sort of where we're stuck with. We don't really know how to do that. There's so much information, and that's why Genelex has made available the UScript software program, which is a drug interaction program that also incorporates pharmacogenetics, but also shows pharmacokinetic changes or predicted changes. So here you see metoprolol is expected to increase greater than 200% in a CYP2D6 poor metabolizer. What will you do as a clinician? You'll probably either use a lower dose than standard, or you'll use an alternative beta blocker. Here's dextroamphetamine, a component of Adderall, and you see it's increased approximately 200% because of 2 reasons. Cymbalta being a CYP2D6 inhibitor, and because of the patient being a CYP2D6 intermediate metabolizer. That combined effect is picked up by the program to display a pharmacokinetic change, and as a clinician, you're going to be watching out for insomnia, agitation, irritation, weight loss, appetite loss. You may want to consider decreasing the dose, or you may consider Ritalin, which utilizes an alternative pathway, something the program will guide you towards. Why is this important? Well, this is representative of the number of potential interactions with just looking at drug-drug interactions. As you increase the number of drugs, so here's 10 drugs, you have about 45 potential drug interactions. That's too many, and there's very smart people in here, but that's too many for anyone to remember. So we need additional tools to help us do this. Okay, interaction mechanisms. I'm just going to survey quickly the different drugs we've been discussing, especially related to treating pain and how genetics influences them. So here's your opioids. These are the opioids that are CYP2D6 dependent: codeine, hydrocodone, oxycodone, and tramadol. With codeine, it's pretty simple. So this is just a picture of oxycodone, but you could essentially, for all of these opioids, replace the parent molecule here and put its metabolites here. But for codeine, it's pretty simple. It gets metabolized by 3A4 to inactive metabolites, and it gets metabolized by CYP2D6 to morphine. Morphine has all of the activity. If you have a rapid metabolizer of 2D6 and you're giving someone codeine, they're going to create more morphine. Probably not going to hurt people, probably a beneficial interaction, unless you have that post-surgery tonsillectomy patient, a kiddo, who then this drug is contraindicated in. Or if you're treating a breastfeeding mother who is creating more morphine and that gets transported to her breast milk, that's now going to be a contraindication. Hydrocodone and oxycodone, they're a little harder to gauge in terms of what this effect is in poor metabolizers, for example, of CYP2D6. If you block this pathway, oxymorphone is obviously the more potent metabolite. And the thing is, though, oxycodone also has binding affinity for the mu-opioid receptor. So how much does this influence pain response? We don't really know. If your patient says they're not doing well and you're having to increase the dose and they're a poor metabolizer, perhaps it is because of this mechanism, but perhaps it's not. You get into trouble, though, when you start blocking both pathways. So you block 2D6 and 3A4 and 5, you accumulate oxycodone, you could get toxicity. Or you block this pathway here, 2D6, and then you put the patient on a carbamazepine for mood, and then you're going to induce 3A4, you're going to shunt all of the drug through into noroxycodone. That has very little activity, and you're probably not going to get very much response. So it begins to get complicated with some of these opioids. Tramadol is an interesting one. Tramadol, we kind of consider it a prodrug. I don't. The parent molecule has pro-serotonergic activity, and it can decrease the seizure threshold. So you combine this with Wellbutrin, which is a CYP2D6 inhibitor. Yeah, it's a great combination, but you can actually, bupropion itself can decrease the seizure threshold. You can get it into sometimes a problematic situation because you boost those tramadol levels, you decrease the analgesic effects because desmethyltramadol actually has about, I forget the percentage, it's much more of an opioid analgesic than the parent molecule is. And so you're sort of doing yourself a disfavor in some cases by adding that combination. So if you want to avoid that altogether, try a CYP2D6 a drug, an opioid that's not metabolized by CYP2D6. And that's one of the recommendations made. I don't think it was Pergolesi, but a 2014 paper said not choosing an opioid that's not metabolized by CYP2D6 doesn't guarantee you won't have a problem, but it significantly decreases your chances. So here's tramadol. The parent molecule, here's the metabolite. Here's the parent molecule's plasma levels, or let's see, is this? Yeah, plasma levels in a poor metabolizer. They're increased, and you can see they're somewhat decreased and intermediate. Here's a normal, and here's an ultra rapid. So you're seeing a downward trend. Here's the parent. You see the opposite. You have a poor metabolizer. You don't have, the metabolite. You don't have much of the metabolite in the poor metabolizer, but you have a lot of the metabolite in an ultra rapid metabolizer. NSAIDs are primarily metabolized by CYP2C9. So you have poor metabolizer of 2C9. You're going to have increases of ibuprofen, 80 to 170%. Celebrex, 100 to 600% increases. Feldene, 80 to 430% increase. And these NSAIDs are also predicted to increase, although we haven't had studies on these because they utilize the CYP2C9 pathway. Your tricyclics are notorious for interactions with the CYP2D6 and 2C19 pathways. So there's guidelines on many of these through the CPIC guidelines, Clinical Pharmacogenetics Implementation Consortium. This is interesting. If you go to, before I look at this slide, if you go to UpToDate for the treatment of cyclic nausea and vomiting, you will see that they recommend for nortriptyline, they actually have a statement in there that says some patients may not respond at standard doses. In those patients, they may do better on higher doses. What they're referring to are ultra-rapid metabolizers of CYP2D6. They just don't come out and say it, and we need them to. But here we see with imipramine, the plasma concentrations in different types of metabolizers and the doses they need. So a poor metabolizer, if you're treating neuropathic pain, needs 20 to 25 milligrams. Your ultra-rapid metabolizer needs 350 milligrams. So there's a big difference in the dose we have to use to achieve adequate treatment. Antidepressants are for the majority metabolized by CYP2D6 or CYP2C19. Fluoxetine, fluvoxamine, escitalopram, paroxetine, venlafaxine, all metabolized by CYP2D6. For CYP2C19, this is citalopram. It's actually got product insert recommendation not to use more than 20 milligrams in a CYP2C19 poor metabolizer due to the risk of QTC prolongation. Only one way to know that, and that's through a genetic test. So we also notice that many of these, like fluoxetine and paroxetine, are CYP2D6 inhibitors. So you can have a lot of drug interactions with these antidepressant drugs. A special mention goes out to Cymbalta and Wellbutrin because they are CYP2D6 inhibitors. You get into an area called phenoconversion, where you have a patient who's a CYP2D6 intermediate metabolizer. You give them an inhibitor, and you phenoconvert them to a poor metabolizer. So that makes the situation worse. I'm going to let Dr. Pasinki talk about what you see clinically in these situations. Here's just an honorable mention again, anticonvulsants. You have CYP3A4 inducers, so carbamazepine, dilantin, primidone, phenobarbital. These are all inducing CYP3A4. What's interesting about these drugs is it's actually when you stop them, you can start to get into trouble. We often think about drug interactions when we start new medications. There's going to be a problem. But if we stop an inducer and we have someone on fentanyl, the levels of that fentanyl are going to start to go up over a couple of weeks as the inductive effects are going away. And that can cause problems, especially if you start to increase the dose of fentanyl simultaneously. You can get into some trouble there. So keep that in mind. Beta blockers, a lot of beta blockers were discussed yesterday. These are all CYP2D6 substrates. They usually have a pretty wide margin of safety, but we've been talking about patients with POTS and patients who are pretty sensitive to some of these issues. So you have to be pretty careful. Here's a poor metabolizer, the AUC of metoprolol, compared to a normal metabolizer, compared to an ultra-rapid metabolizer. So quite a bit of variation here. For children, focusing on children, these are sort of the key drugs. Of course, all of the other drugs apply because they are oftentimes metabolized by the cytochrome, but these have a lot of evidence in children. So codeine, I've already talked about some examples. Strattera has specific dosing recommendations in the product insert for CYP2D6 poor metabolizers. Celecoxib should not be used in juvenile rheumatoid arthritis patients who are CYP2D6 poor metabolizers. Chloramphenicol is our classic example of ontology, where the enzyme system actually is not fully matured in young infants. So you can, the classic example is gray baby syndrome. Azathiopurine and 6-mercaptopurine, you have increased risk of myelosuppression, myelotoxicity with TPMT poor metabolizers. Carbamazepine, again, if you have this mutation of HLA-B, it increases your risk of Stevens-Johnson's. Should not be used in patients. You should choose an alternative in those patients. Simvastatin in the SLCO1B1 transporter, if you have a variant of this transporter, it significantly increases your risk of myalgia and rhabdomyolysis. And the VCOR is extremely beneficial. It's the warfarin receptor for optimizing doses of warfarin, especially in children. So overwhelmed, Dan put this slide together. I think it's great. It's really pretty pragmatic. You essentially align the drug you're giving with the pathway that's inhibited or that's deficient in that patient. And if you see that there could be a problem, you adjust the dose accordingly. These are some recommended readings that go into this in more detail. We have an excellent software program that can help utilize this in practice. So my daughter was terrified. She just turned 2. She was terrified of her doctor. And so we started watching Dr. McStuffins. And we got her this outfit, and she wore this outfit to her last doctor's visit. And she was actually doing a checkup on the doctor. So if you have a kiddo scared of a doctor, I recommend Dr. McStuffins, and that's my son.